Hi everybody, I am constantly saying it, but I'm very privileged to know so many wonderful colleagues in the field of women's health. And it's really a delight for me to be able to have my learned friend and colleague Amelia coming on today to talk about her role working with women who are recovering from breast cancer. And today we're going to be primarily talking about scars. What sort of scars are women who have gone through breast cancer treatment dealing with? The ongoing effects that women can really have to work through for many years after treatment ends. We're going to talk about how it affects the lymphatic system from an axillary web perspective, post-mastectomy pain, and then we're going to pull it all together with the role of exercise. So Amelia, thank you so much for coming on today. Can you just tell us a little bit about, who you are, how you got into this field, and why you do it?
Yes, certainly. Hi, Michelle. Hi, everyone. Thank you for having me. I'm, as I say, Amelia Osborne. I'm now a women's health physio. My background, I did sports therapy before my physio qualification. So I spent a number of years while I was studying every weekend as well, kind of doing sports therapy. I think that was really became my passion, a bit more for hands-on connective tissue mobility work, I think. And then obviously going through uni and everything, as you do, you have an open mind, but always wanted to go more into the MSK side of things. And then through my years in MSK, I kind of specialised in MSK in 2011. And then through that got more into the women's health side of things, and with that as well, also MSK, the mixture, just noticing scar, how many people obviously coming through the door with all different types of scars. Particularly became more interested in the kind of women health issues, C-sections, and then the scarring, all that side of things as well. And around the time as well, it was where I worked as a breast centre as well, and some of my senior colleagues were just starting to see some of the post-mastectomy breast scar work coming through, and that's really started to, I saw one or two ladies, and that really sparked my interest into the scar work side of things, and just how much difference it can make, and what, the changes you can see really. And then from there I went on to do Willie Fury's course, who is just amazing, oracle, fountain of knowledge, and that was just really sparked my interest in it, and I found it so fascinating, just such a great anatomist. And then from there I've been I kind of took over the breast service where I work, NHS wise, and it's just really gone from strength to strength. I suppose it's getting busier, unfortunately, but it's nice to see more people coming through at the right time, which I think is still really not that established from a physio perspective, the difference that it can make really. And I think unfortunately still some consultants are referring through just for range of movement and don't really see the connective tissue side of things and the importance physio can play in that really. So yeah, that's me up to date now.
Brilliant. I think there's a couple of things there that I think just kind of bear maybe a little bit more exploration, because I feel in physio generally at the minute there's almost been a little bit of a move away from manual therapy, which worries me a little bit, because I think particularly in the oncology field, I think the ability to put your hands on somebody, to calm down their nervous system, to touch them with kindness, particularly with breast cancer, because you're not administering a chemo IV, you're not doing surgery, you're actually moving them back towards function and almost kind of restoring that relationship with their body again. So I think that's really important. But breast cancer related scars are not like normal scars, because of course we have to be very respectful, don't we, of the lymphatic system and of the progressive nature of radiation if they've had radiotherapy as well. So what sort of different scars are you seeing in your line of work? Give us an overview of what you're seeing.
Yeah, so we're getting obviously a variety, like you said, touching on exactly, Michelle, the huge difference as well with these catchment, this group of ladies, is they've often had, with the lumpectomies, or what they call wide local excisions, they've also had often axilla surgery, so where they've had the lymph nodes obviously disruption, so they might what's called a sentinel lymph node biopsy, or they might have had a full lymph node clearance, along with, as I say, the lumpectomies, the mammoplasties, or the actual mastectomies as well. So they're the majority of things that tend to come through from the ladies' point of view. We also occasionally get some men through that have still had axilla surgery as well. And then obviously we get reconstructions as well. So we've got a regional centre over at Wiston. We get quite a few referrals from there. So then we're obviously not only dealing with the breast scar itself, but we're dealing with the transplant site as well, whether it be tummy or thigh or whatever. So then you've got two major areas of scar work as well.
Absolutely, yeah.
So they're the majority of things we're seeing.
And what sort of reconstructions are you seeing? Are you still seeing many trams, or is it mostly dieps and tugs and omental flaps?
Yeah, it's mainly DMs that I get referred through. I did see just have had too much tugs recently on younger, obviously slimmer women, but the majority seem to be the DFs. I still get a few from our own hospital, which will just be maybe they're expanders, so they're going to implants, but the big surgeries are those, the DF and the tugs. Yeah.
I think, and are you mostly seeing immediate or delayed reconstruction where you are? Because there seems to be a huge variety geographically.
Yes, yeah. I would say the majority seem to be the delayed, and I think unfortunately, I don't know if it's just our site, but there seems to be quite a big wait, 18 months to about 2 years, which I think they allow, like you say, psychologically a year to let things settle, make sure it's definitely the right decision for the ladies involved. But I think again that's where physio plays a big role, because I've had a few ladies referred through that I feel like their initial problems span from their initial axilla surgery and not from the reconstruction, but because they never got to see physio initially, that's whereas the ladies that I managed to see, you know, through the treatment, through the mastectomies or whatever, that then go for the reconstruction, I think from my point of view tend to do a lot better down the line.
Yeah, and I think as well, you know, I don't know, are you seeing many women for prehab? That seems to be, you know, a growing area as well, certainly in the literature. I'm not sure how it translates again kind of geographically into practice, but it makes a lot of sense, doesn't it? Because the better shape you are going into surgery, the better your outcomes are going to be.
Definitely. Yeah, I think unfortunately it's not that big a thing where I am. I think it could be. I think it's definitely got a scope. And I definitely think the ladies that are fall under us anyway, like that are having the delayed reconstruction, that's definitely something I will keep them on, bear them in mind for the prehab going into the reconstruction really. I think also the reconstruction, our regional site, they even do like almost prehab, you know, like orthopedic school or joint school, they almost do a bit of a reconstruction school as well from an education point of view, which I think is really good.
That's fantastic. And I think as well, it's really important from a biopsychosocial perspective, isn't it, for the patients as well, because you're giving them education, you're preparing them, but you're giving them some independence and some power over their own health as well. You know, in a world where a lot of it is just passive, you know, things are being done to you. This is a great way to take control.
Hugely. And I think, like you say, Michelle, this catchment of patients, it's a huge psychological element as well, and all the self-esteem, everything that comes with that area as well. I think, like you say, anything that you can give them back, especially when everything's been done to them with the cancer, and then a lot of ladies would report when that's finished, it's like dropping off a cliff almost. They feel that support network suddenly just dissipates. So I think it's nice to give them bits to enable them to self-manage is again another key area.
Absolutely. So at what point are you seeing them post-op? Are you seeing them fairly quickly, like, or are they waiting for their 6 or 8 week checkup, or how soon do they get to see you?
Yeah, it depends. The clinic where I work, they're normally quite good. The main consultant's quite good and on board with physio. So often they'll tend to be picked up It depends if they've got what we call cording, which I know we're going to go into a bit later, but they might be picked up in clinic at their 2-week review and tried to be fast tracked through. Again, we have got a few delays, but we'll try and see them as quickly as possible. But it does, again, it really varies. We get ladies that are a bit further down the line, months down the line, that might have only just noticed it, or they, again, I suppose it's like they've never been through it again, so they don't want to know what's normal, and it might only be someone saying, oh, actually you should be able to do X, Y, or Z, and then they get referred through that way as well.
Perfect. So where do we see
and then obviously the reconstruction.
Yeah, absolutely.
Sorry, no, don't worry.
We've got a little bit of a delay, I think. Where do you see the intersection then of scar work for somebody who's gone through breast cancer and connective tissue, fascial work? You know, how do you see those two coming together?
I think it fits together perfectly, because obviously every scar is a huge disruption to a fascia. So obviously the scar, it works hand in hand really. Obviously the scar is a bit like the top of the iceberg, I feel, and then obviously underneath that is the huge, or the fascial restriction and the connective tissue. So I think they form hand in hand really. I feel like you can't work one without working the other really.
Absolutely, yeah. And again, I suppose it's looking at the whole woman. You know, she's more than just her breast cancer, you know, or her breast cancer treatment. What's her general mobility like? And have you seen, you know, there's not a huge amount in the literature that I've been able to find, but certainly women who are on hormonal treatment as well, whether that's, you know, the aromatase inhibitors or tamoxifen, I think we have to factor their effects and the lack of estrogen on tendon health as well, you know, and that's another aspect of the picture too, isn't it?
Definitely, and I think you might see in these ladies, and they're viewing them more holistically. I think the common side effects, they'll often report multi-joint pain, unfortunately. And then I've had a few ladies, like you say, the tendon you've got to look at with, you know, Achilles tendonitis as well along that journey. And so I think you're right. I think there's definitely, which it doesn't seem to be, there's not much out there to say that would just be from my patient experience. I definitely feel like there is that connection on other issues.
Yeah. So I want to talk to you, I want to hear your opinions on axillary web syndrome, or as it's sometimes called, cording. If you could give us a little bit of background into that, and then what's your perspective? How do you manage it?
Yeah, of course. Again, as you know, I'm sure, Michelle, it's relatively it's quite prevalent, but it's considerably underreported. And I think even specialists within the field, this has been another push for me to try and publicise it. I've recently been treating a local GP who went through breast cancer, had quite significant cording, didn't herself know anything. I've spoken to all her colleagues within her GP region, they didn't know anything. And I think a big push towards just making more awareness of it. I think the most recent general practice journal, there was an article of that in like August time, to again just raise this awareness, you know, for people suffering with it. They still, as far as I'm aware, Michelle, correct me if I'm wrong, but they still have limited definite diagnosis on the histopathology of it. As far as I'm aware, it's like you say, that obviously they've had interference with their axilla, they've had axilla surgery, and any lymph disruption, as far as I'm aware, can potentially cause what we call cording or axillary red syndrome, which is almost, I kind of like to see it as it's the scarring. So the axilla, so the lymph nodes have been taken away, but the vessels are left over. So it's these vessels that almost fibrose, and then you're almost left with this tight band of, it's essentially like small cords, elastic cords within the axilla themselves, that can travel down to kind of cubital fossa over the elbow and even into the wrist as well. It can develop, you know, anything from early days post-surgery to months after, but I tend to think it's those first few weeks, that first month, again, stages of healing. I keep trying to see if there's a correlation, if the ladies are doing too much within that, you know, early stages, but not necessarily. I wouldn't say there's a pattern to it. I know some of the research shows that sometimes younger patients with lower BMI, again, have a slightly higher prevalence, but again, I would see all different shapes and sizes, activity levels. So I can't really see a pattern from that way. But they normally present, so they present in clinic with reduced range of movement of the shoulder. Like they often would report they feel like someone's almost got their string there or elastic and they can't straighten it out. Or the ladies might put real like a sharp pain within their axilla itself. Other ladies as well have had referred, which isn't as common, but almost cording down into their chest, so almost inferior anterior chest wall as well. And again, they might refer through with anterior chest pain as well. So I like to, when they come in, obviously assess range of movement, and it's normally quite evident as soon as, particularly in abduction, normally kind of past shoulder height, so past 90 degrees, particularly flexion abduction, and you can see that often, you can see that real tight band, and sometimes you can even see it coming out superficially as well over their arm. So then I would obviously go on to treat them, which how I tend to deal with them again is based from Willie's Fury, which is basically tissue glide. So we treat them in supine, getting them into a comfortable position where, maybe slight abduction. And then, as I say, it's based superficial tissue glide. So it's trying to find where they are initially, which sometimes is very palpable and very obvious. And then basically it's hands-on work, and it's a slight cause, it's a slight distraction, and sometimes they will go, especially the superficial cords as we call them, will go quite easily, and they'll pop and you'll get that audible release. And sometimes on those patients that are quite acute with them, the patient literally, the change in the range of movement can be instant. And they're the real ones to get on. Straight away you've got those patients on board, which is really nice to see. Then you've obviously got your more chronic ones that I would do a lot more. It's trying to always, a bit like that investigative role as any physio is trying to trace back and find where the origin is, and sometimes it might be coming from, this is where that overlap as well with the scar tissue and the fascia come in. Sometimes you might be able to trace it back to their initial scar, their axilla scar, or to their actual breast, the chest wall scarring as well. So I wouldn't say any two cases are the same. Every case, involves a slightly different handling and a slightly different treatment, which again comes back to, like you say, in the day where physio tends to be very hands-off. I think that was the revelation through going into connective tissue work, and Willie Fury was, get back with your hands on, learn to trust your hands again, and show you where it takes. Which again, I think this treatment it is a little bit about being intuitive with your hands and treating each different patient differently.
Yeah, I think I would agree with 100% with everything that you've said there. I find that the scar is often a big driver with cording, and oftentimes if you can get a little bit more mobility around the scar and that area, you can get really nice fast results. But I think as well, it can be indicative of a little bit of lymphatic overload. So absolutely, after releasing the scar, maybe to do a little bit of MLD to show the patient how to do some self MLD, and then the exercises are obviously key, to getting that back again. But I think it's one of those situations that can be very disabling for a patient, and there's a relatively fast solution. If we can get in there early enough and get that mobility back, and we can stop almost like the dominoes of decreased shoulder and even upper limb disuse and disability. Because
like you say, when you look at the statistics and some of the morbidity of the arm is really interesting.
But I think as well then, if you're combining somebody.
Oh, sorry, I think we've got a bit of a delay.
It's all good. Here we go.
I think we're okay now. I can hear you.
Okay. So I think, if you have a situation where you have a woman who's maybe had neoadjuvant chemo, she's had surgery, she's maybe had some radiotherapy as well, maybe as well as the cording and the scar issues, she's maybe also got some peripheral neuropathy going on, but she can't move the shoulder, so she's less inclined to move the hand, and you can just see how that whole cycle of disability can just roll, and then what happens in terms of bone density, in terms of heart health, just in function and quality of life, And I think it's really important that we get people hands-on. You know, I think it's vital, isn't it?
Definitely, like you say, that unfortunately that knock on, that downward spiral, and like you say, the chances then of developing lymphedema are greater, the chances of obviously reoccurrence if you're not physically active. All the statistics for that show that reoccurrence is higher if they don't get physically active. So you're right, and then the anxiety associated with all that spiral, it is.
So we can actually just, you know, we can stop that direction, and we can actually turn it around, you know, and just the level of reassurance I think that brings.
Definitely.
So I think it would be safe to say that we are both very pro manual therapy in this situation, you know. So we've talked about a lot of the indications. What do you feel are some of the contraindications or precautions that you would like manual therapists, whether they're physios or, you know, massage therapists, you know, whoever, what do you feel is really important to know about manual therapy, scar work, in terms of being safe with these women?
Yeah, I think you're right. Again, because of the catchment of patients we're dealing with, you have, like you say, you've got to be very aware of all of those. I think first things first, especially working in, if you're not associated or close to, it would be getting the okay, the go ahead from that patient's oncoplastic consultant or their oncologist that they're happy for them to have some hands-on treatment. Obviously, where they are in their treatment cycle for the actual cancer as well. So whether it be the chemo, I would certainly still treat when the ladies are having active chemo, as long as they feel physically well enough to have treatment. And I would try and target it if they've got a cycle with the chemo. I would try and target it when they know they're okay, like depending on the cycle, it might be week 2, and then I'd see them that every cycle. The radiotherapy, as far as I'm aware, I would not touch that radiated area for 2 to 3 weeks after they've finished the radiotherapy treatment. But if ladies are still, like you say, they're seeing me anyway, I would still have them come in, again for that reassurance, a bit of hands-on, but I would obviously treat, you know, their distal symptoms or away from that radiated area. So we're still working on some things. The other obviously precautions as well is the wound healing, just checking that they're obviously clean and dry, they're not dehiscing, there's no opening, there's no weeping, there's no sign of infection. The other thing is, I suppose, cellulitis as well, just checking, you know, for any redness, heat, your normal infection signs. And obviously lymphedema as well. It's, I think, a bit risk versus benefit. Where we are, we have almost a separate lymphedema service that that they would kind of ask to refer, or they would refer into me. But I think sometimes you've got to look at it, like you've said, Michelle, is the scar, what's the main potential issue that might be causing the lymphedema and that knock-on effect? If it's potentially the scar that's not allowing lymphatic drainage, then of course they need scar work would be your priority. But I think it's weighing up all like those say. But as far as I'm aware, they're the things that I just consider before I would get hands-on with. And I suppose the other thing as well, sorry to interrupt, is the patient. If they're, I think because it is such a sensitive area, I always check, you know, I will ask those sensitive questions. Have they looked at the scar before? Have they touched it? Are they touching it regularly? Because if they haven't looked at it or touched at it, I'm not going to go straight on and put my hands on. So again, it's that sensitivity and, you know, tentatively sussing out where the patient's up to with their kind of sensitivity and their body awareness and things like that as well.
Definitely. I think those are all really important points. I think to be aware that you're never, you know, if you're doing massage or any sort of manual therapy, connective tissue work, that we're never pushing fluid towards compromised lymph nodes, you know, to be really aware of that. But I think, you know, I was just at a meeting the other night for, you know, it was an overview of the new ACSM guidelines for exercise and cancer. And they were talking about the importance of, you know, making every contact count, in that we really want to be quite sure that even if patients are, say, in a situation where maybe manual therapy is not the main focus of a session, that we're still really underlying the importance of movement during and after cancer treatment. That it's non-negotiable, you know, that and it has to be a lifelong commitment, really, in terms of dealing with the side effects, preventing recurrence, decreasing the risk of disability, I think it's really important that we do integrate movement and exercise into every session that we're having with these patients.
Definitely.
Yeah.
Definitely.
We touched a little bit when we started talking about pain. And I wonder if I could just get your thoughts on post-mastectomy pain syndrome, because that's, I think, you know, we talked about other issues being under the radar. That for me is just, it's not, I'm not hearing enough people talking about it. And it's a major, major problem for a lot of women. What's your experience with dealing with it?
Yeah, I would echo exactly what you said. There really doesn't seem to be that much awareness out there, and there's this whole group of women that are kind of left with the acute side effects of cancer have kind of dissipated, and unfortunately they're left with the chronic kind of long term, often this post-mastectomy pain syndrome. Again, I think it could almost become an umbrella, or umbrella term for not ladies that not necessarily have mastectomies, that they've had other breast surgeries but still have this ongoing pain. So I mean, Michelle, correct me again if I'm wrong, but as far as I'm aware, it's the persistent pain, the chronic pain that persists longer than would be expected for the normal tissue healing. And as far as I'm aware, again, it can affect sensory nerve symptoms, so your normal burning, your pins and needles, your lacerated, that kind of nervy pain. But then I think they're also thinking potentially it can have an effect on the motor nerves as well, so you can get the cramping, that chest spasm as well, which I think can often, get misdiagnosed at whatever level, whether they go to the GP. Often they'll say, that time they've got costochondritis and then refer them through, or just often we'll give ladies, non-steroid anti-inflammatories and just send them away to kind of just get on with things. So again, I think obviously looking when a patient comes in, it's looking what else it could be. So checking, like you say, checking they've got no cording, checking that scarring might be contributing to it. Also as well, thinking about potentially thoracic outlet. Is it the scalenes? Is it all that area as well that could potentially be pinching the nerve? Not necessarily it being compressed at the axilla. Could it be higher up because of all the secondary compensatory things as well? So I think they're all the other issues I can look at to see if we could have an effect on it as well. I know a few ladies as well have had, neuropathic medication as well, maybe just at night as well, just, I suppose as a differential diagnosis to see again if that can make any. I probably don't know enough. I need to know more, but there isn't much out there too.
There's really not, is there? I mean, and I think, what I've seen is that for women who've gone through breast cancer and they're left with this pain, or if it's a new onset pain, maybe because of post-radiation fibrosis, the aggressive scarring that you can get with that, the first thought whenever there's any new pain is it my cancer back?
That anxiety is huge. That's been a shock to me, that I think that out of all patients I see, that I think has to be one of the biggest side effects of cancer treatment, is anxiety that they're left with. Unfortunately.
And I think the other thing, I suppose, just to be aware with from a differential diagnosis would be, this again, I seem to keep saying this, but the effects of cardiotoxicity, on women after breast cancer treatment. Most women, I think the rates are somewhere up around 50% of mortalities after breast cancer treatment are actually due to cardiac events rather than breast cancer. So
I did not know that was that high.
It's shocking, isn't it? I think it's really important that we are aware that women having a cardiac event are going to have different signs and symptoms to the classic male scenario. Where the cardiac health is compromised by chemo, by radiation, by aging, by lack of estrogen. But I think, like you were saying, once all those big guns have been ruled out, I think this is really where movement, obviously, and using manual therapy skills if there is a bio driver. But I think pain education can really be quite useful here as well. Taking that kind of Moseley-Butler model and explaining pain, and really just decreasing the stress level, calming down the nervous system a little bit as well. And again, I think that kind of leads us nicely into talking about how exercise can really pull a lot of what we've been talking about this morning, pull it together. what do you
Definitely.
see as an ideal exercise pathway? Are you able to signpost your patients into an exercise strategy?
Yeah, I'm really lucky actually through the Macmillan team where on the area I work, they're running just a trial at the moment. It's not rolled out, but I think it's with support with the local authority that they can offer a one-to-one initial assessment with patients and then offer them a 3-month kind of gym pass to all the local, which again, you think of obviously cardiac rehab, you think of pulmonary rehab, often these groups of patients have that ongoing importance of exercise, but again I think it's lacking with the post-cancer treatment patients. And like you say, when you look at all the statistics on the reduction chance of reoccurrence with the effect of physical exercise, it's huge. So, I mean, obviously I do as much as I can one-to-one in sessions. So they're sent away, like you say, from day one with their own homework to start that self-management and ownership, and encouraging them throughout. I mean, the great thing about this scheme where they run locally at the minute is they will support them in the first time that they go to the gym or that they go, often like you say, ladies going swimming, if they've had a mastectomy, it's that all those other personal issues that come along with it. So they will go with them that first time or let a friend go with them as well to reduce another barrier to let them exercise. And then, you know, the difference I've seen in some patients after, like you say, they change their whole life. They become more active than they ever were. And to see the difference in everything, mental, physical well-being is huge. And I think, like you say, it can totally spin it and change it so they're much brighter, positive about their outlook, and obviously, like you say, reduce the anxieties and all those knock-on effects as well.
Well, I mean, I'm just kind of looking at the guidelines. This is one of the pieces of literature I picked up the other night. You know, the 2019 exercise guidelines for cancer survivors. Strong evidence that aerobic exercise decreases anxiety, depressive symptoms, fatigue, quality of life, perceived physical function, improves sleep, improves bone health. And then resistance training decreases fatigue, decreases quality of life, is safe with a couple of precautions for lymphedema, and increases perceived physical function. So their recommendations now are for aerobic exercise, moderate intensity, 3 times a week, 30 minutes over a 12-week period. So that would tie in nicely with what you're saying about a 3-month period. And then resistance exercise of the major muscle groups twice a week, 2 sets of 8 to 15 reps at about 60% of their 1 RM. So I think it's great that we have some literature to support what we actually know, you know, on a clinical level works really well. And then it's hopefully to kind of keep getting this message across that movement is medicine, with precautions obviously for lymphedema, you know, that you start low and you go slow and just kind of build up. But I think, you know, if there's really no bad option. You have to pick an exercise, I think, that somebody's going to enjoy doing. There has to be some fun in it as well. Whether it's walking or swimming, you know, or getting on a bike or lifting weights, doing Pilates, doing yoga, movement is just non-negotiable at this point, isn't it?
Definitely, yes, wholeheartedly. It's like you say, when you look at those statistics, how could you not recommend that? Like you say, how could you not?
But I do think that a lot of physios who are maybe not working in the oncology field, and a lot of fitness professionals maybe, and massage therapists are nervous.
Of course.
You know, and I think we have to do a little bit of myth busting. We absolutely want to create an arena of safety, but we have to do a little bit of myth busting as well, I think, don't we?
Definitely. I think, like you say, unfortunately, there's that whole, like you say, the worry, obviously, about spread and all of that, like you say. So I think education is key. And I think in a lot of departments throughout, you know, there's still a lack there of a nice, straightforward pathway, because often, sometimes your normal MSK don't want to see, you know, the cancer oncology patients and all of that. So I think that is, again, a big drive to educate as many people as possible. You're right.
And I suppose, you know, just kind of to wrap it up then, because you have a couple of different hats. You've got your MSK hat, you've got your women's health hat, and you've got your oncology hat. And, you know, we could spend another hour talking about the pelvic health implications of breast cancer treatment as well, and how that can be a barrier for exercise too. So it's really important, because what I've seen is that a lot of women's health physios are scared of the cancer diagnosis, but a lot of oncology physios are scared of the pelvic health end of things as well. So we need to be able to, again, look at that big picture and pull it all together for these women, don't we?
Yes, and that's, like you say, it's lovely having that knowledge to be able to see the interlink between them all as well.
Absolutely. Amelia, thank you so much for sharing your wisdom and your experience. Are you just in the NHS or are you in private practice as well?
No, I do work private practice as well, just one day a week. And again, it's trying to get patients through quicker, because obviously it can be frustrating with the constraints of NHS. So sometimes it's nice to have that option, you know,
so
to
where can
get
people,
through quicker.
if people wanted to refer patients to you privately, where is your clinic based?
Yeah. It's based on the Wirral. It's called Wirral Sports in Williston, and I'm working under Becky Corrin, who's pelvic health physio. So if they could just Instagram either breast health physio or web pages pelvic health physio, and they can find all the information through there as well.
Absolutely. And again, you know, follow you on social media and just see all the good things that you're up to.
Thank you so much, Michelle.
Thank you so much, because, you know, I think it's so valuable to get experts like you in to talk about what you're doing and the effects of what you're doing, that you're actually seeing how you're literally changing women's lives, you know, on a very fundamental level. Because I think we have to start looking at breast cancer more as a chronic disease now, particularly with the gains that we've made over the past decade or so. Women are living longer, you know.
Definitely,
what
you're
can
right.
we do to help them live well?
Definitely, that's so true. Yes, excellent. Yeah.
Thanks, Amelia, and I will talk to you soon.
Okay, take care.